Okay, Craig Stevens here again, Spokane Sports and Physical Therapy. We're going to expand testing and knowledge of the lateral meniscus. Not lateral joint pain, but lateral meniscus pain. So a couple of things here before we start. If you're a patient, this is what you would feel if you have a typical lateral meniscus problem. So typically, a meniscus problem is some kind of injury involved, okay? Now, the lateral meniscus injury is a little bit different than the medial meniscus. The medial is more common, but the lateral meniscus injury typically involves a moment where the foot is planted and the body goes one way, or you're pushed this way. Typically involves a rotational component, the foot planted on the ground, and the foot twisting or the hip twisting. Some people will complain of popping, but not always popping. Popping is not always a guarantee. Now, another thing that we learned in school is, well, a meniscus tear means clicking or popping. Again, not always, especially after it's had some time to swell. So be aware of the injury time if you're a patient. Typically the next day the knee is really swollen, it feels junky, doesn't want to move, and with a lateral meniscus tear normally, or lateral meniscus injury, you can't straighten your knee. So straightening is the first thing you notice. The second thing you notice, you can't bend it all the way back. So you can't get down into a deep squat position. You'll just pass out with pain. All right, so those are kind of some of the things that we see with the lateral meniscus problem. So how we test this? Now, there's a lot of tests for the meniscus that we use as practitioners. But when a meniscus is irritated and inflamed, the last thing you want to do is make it more inflamed or push a tear or do things. So I advise all my kids, my students, be gentle when you're checking for a meniscus, even an initial injury. You want to be careful. Don't get violent. I'm not a big fan of the lateral pivot shift test, which I'm not going to go into because I'm not a big fan of it. I think it's too harsh. I think there are better ways of testing the meniscus. And we don't have X-ray vision or MRIs where we're at usually, so it's hard to test the meniscus right away. So we want to come up with an idea of whether we think the lateral meniscus is involved. All right. So one of the best ways we do this, and this is not, I didn't devise this, I learned this, is get the knee into a fairly relaxed position. And then what you want to do is you want to go into a Valgus stress test. And Valgus means away from the body. So what I'm doing is I'm holding this, stabilizing the outside of the knee, and I'm pushing the foot this direction, laterally. And as I laterally push that, I compress this joint line, okay? Normally, the meniscus tears on the outside, on the periphery. So if I compress the knee, if I compress that lateral meniscus or that outside structure, it's going to elicit pain if we have damage or involvement of the lateral meniscus. So once again, bring the knee into this a slightly extended position, not fully extended position. Hand up near the fibular head, thumb on the tibial plateau, on the tibial tubercle, and then I gently move into a valgus position, and I'm looking for pain. And I ask the patient, does that hurt? Does that hurt? Okay? Now, as I'm doing this, I'm also gapping the structure. So this is actually an MCL test, okay? Or a medial stress test of the medial structures. But I'm not looking for that right now. All I'm talking about is a lateral meniscus. So, typically what will happen is with a lateral meniscal tear, right away, as I do this valgus stress, as I compress this lateral joint, woo, it hurts. It's like a blister, it's like a boil. It hurts. So then I know something in this compartment is being pinched, pressed, is very unhappy. Okay? The second thing I will do, if I don't elicit that, I will then go into a more flex position and do the same thing. This is a little harder, so I'm going to demonstrate from here on the outside. I usually am in front of the patient when I do this, but again, I will push the knee, the tibia medially, and then go into a valgus moment into this position to check the more posterior part of the meniscus. Now, sometimes if I'm really, really concerned, I'll bring them almost into full flexion and bring the knee in and do a valgus stress test to see if I've got the posterior horn. If you have a posterior horn tear, which is fairly common, they won't go much past about 100, maybe 110 degrees. They don't move very well into that, and even just a little bit of rotation will light them up, will cause pain. So again, if you're a patient and you can't bend your knee, and you put a little bit of pressure on this inside to compress the outside of the knee, that's going to fire up that meniscus. All right? So be very gentle, especially in the beginning stages. That first week, that meniscus is irritated. If you go and start reefing on this knee, you're likely going to cause more inflammation, more tearing, more problems for the patient. Don't want that. Be very, very gentle as you're causing compression of that outside. And it will usually be immediate, whoa, yeah, that hurts, wow, that's a lot of pain. That's the kind of reaction I get when there's a lateral meniscus injury or involvement. I don't know if there's a tear by doing that, I just know there's involvement. Last piece, and this happens with the more the medial meniscus injury than it does a lateral meniscus injury, is you will feel swelling in the back of the knee almost kind of immediately. The swelling in the back of the knee is a Baker's cyst, and that Baker's cyst communicates with the joint, meaning there's a channel that moves into that cyst. And when the knee starts to fill with fluid because of trauma, that fluid has a backflow valve and it pushes out into the cyst, and that cyst swells up. So you'll feel pain in the back of the knee. They'll say, gosh, yeah, that's really tender. Yeah, that feels like I've got a balloon there, I got a ball there. Well, you kind of do. Baker's cyst. So a Baker's cyst is usually an indication that there's been some kind of trauma inside the joint. Now, a footnote on that. ACL and PCL are not usually causes of a Baker's cyst. Okay? They're intra-articular, but they're extrasynovial, which means they are surrounded by their own capsule. So they don't affect necessarily fluid directly inside the knee joint itself. Therefore, they do not communicate directly with the Baker's cyst. So you can have a meniscal injury and the ACL still intact. Now, last point on this, the lateral meniscus, more than the medial meniscus, will have extraneous tissue damage, such as the LCL. Not as much an ACL or PCL, and that's clinical findings. And you'll talk to a lot of therapists or doctors, and they'll tell you that too. We see a lot of standalone lateral meniscus injuries, meaning you won't find an ACL or PCL involvement, but you will find an LCL, lateral compartment involvement. Okay, so that's a lateral meniscus. If you are a patient and you think you've got a lateral meniscus injury, ice. Try not to put much pressure on it, and do not force motion. This is not something that, well, I could just work through. No, if it hurts a lot, you shouldn't push through it. Don't push through it. Get ice on it. Within 2 or 3 days, if it's not significantly better, yeah, you've got something going on inside your knee that needs to be looked at. Okay?